really is my pleasure and honor to introduce Emily Johnson, who is a very good friend, most importantly, and colleague, who comes today from Northwestern. She's an associate professor there. And if you take a look at her CV, it's incredible, all the things that she's done. She was raised in actually Ann Arbor, and then did college at Emory. Came back and did her, I'm forgetting where med school was, Michigan. Of course, how can I forget? Go Blue. Yes. Go Blue. And residency, Michigan. Go Blue. Exactly. And then her fellowship she did in Boston, and she simultaneously, while she was there, did a master's and a PH. And talk about somebody who really has capitalized on her training. She's done fantastic work and is really changing the field of pediatric urology. And as we learned last night at Journal Club, she just has amazing anecdotes and experiences to tell, the backstory that she calls it, which are the true life lessons that we get over time, learning with our research, more than just what you see in the publication. And she's contributed just enormously to our field in different ways, in ways that she didn't originally think that she was going to focus. So on a very impactful area of neonatal circumcision that we'll hear more about, but really using her health services research background and looking at disparities in care. And then really focuses her clinical work on care for DSD and fertility preservation. And she's really leading our field in this area. And I'm really excited for her to share her work with us today. So help me in welcoming Emily Johnson.
Good morning, and thank you so much, Hillary, for your invitation. Thank you to the Peds Urology team for welcoming me so far. We had a lovely time yesterday, went to DSD case conference, and then we went sailing. So it was a nice intro to the team. Today is a little more business, but I think will also be really fun. So this is truly like a highlight of my career to be able to be here with you and share a little bit about what we've been thinking about and working on in Chicago, and just learn from each other. I love when we have visiting professors and can just hear about different ways that we approach cases and think about patients together. So I'm really looking forward to doing that as well. We have until 8, right? So over the next 45 minutes or so, I will share my perspective on DSD in 2025, trying to answer the question, which outcomes matter, which is a hard question to answer. So here we go. I do not have any disclosures. Just by way of introduction, this is our hospital. So this is where I'm coming to you from. Lurie used to be Children's Memorial Hospital, and right before I joined, we were renamed due to a very large donation from Ann and Robert H. Lurie. This is our downtown location. The Lake Michigan is over here. This is our lobby that's actually being remodeled right now to improve patient efficiency with check-in. And we're a very vertical hospital. So the ORs are on 2 floors. There's a lot of space, but they had to build up because there wasn't very much space to build out. So this is where I work, and it's beautiful. The lake is right over here. I will admit to you that in DSD and in taking care of this challenging patient population at Lurie, there are definitely more questions than answers. We sort of figured that out yesterday, I think, going through the 4 patients that we talk about, but I hope to at least give you some food for thought. The goal here is really to think about what type of outcomes matter and whose perspective we're thinking about these from. Historically in this field, there's been a lot of focus on what we as the physicians and as the medical field think is important. And it's turned out that maybe that's not correct, or maybe not the whole story. So I hope to provide you sort of some different perspectives about how to think about patients with differences of sex development. Like all things DSD, how to think about outcomes in this patient population is highly individualized. And you can have a patient that presents with the exact same diagnosis and clinical scenario, but they come from a different country, they come from a different religion, a different family structure, a different way of looking at the world. And what you might end up recommending or deciding together may be entirely different, even though their phenotype and genotype are the same. So over the next few minutes, I'll provide you just a little bit of a background overview of DSD, just make sure we're on the same page about what we're talking about. I'll talk a little bit about our current care model, kind of how we think about taking care of these patients at Lurie. We'll then talk about outcomes and what might be important, and then I have a few case examples to sort of take you through a thought exercise. Here's our objectives. So I'd like to start with a few definitions and just chat about the historical approach. DSD, I've been throwing around that acronym. We can't even agree on what it stands for, but disorders or differences of sex development are congenital conditions in which development of chromosomal, gonadal, or anatomic sex is atypical. And that quote came from this paper in 2006, which is referred to as the consensus statement. This was a result of a meeting that actually happened in Chicago, so some people call it the Chicago Consensus Statement, where it really outlined some of the updated principles of care for this patient population. And one of the big recommendations from this statement was an adjustment in the terminology. So you can read the paper if you want to see all of the updates, but that what we call these conditions was one of the most important updates. And because there's not agreement amongst individuals with these conditions or the medical community, you're going to hear a lot of different words to describe the same thing, which can be confusing. So if you hear intersex, then differences of sex development, congenital conditions affecting reproductive development, variations of sex characteristics, so VSC is now in vogue. They're all basically talking about the same thing, where sex development did not happen according to the binary pathway that you learn in Bio 101. And this is a really wide range of conditions that we care for that sort of fall under this umbrella. As I alluded to, there is no preferred terminology. And so it is really important if you're taking care of these patients to check in with them and see what they prefer, what resonates with them. If you talk to a lot of these patients who, let's say, might have congenital adrenal hyperplasia or mixed gonadal dysgenesis as a few examples, some of them might never have heard any of these umbrella terms that you would use to describe their condition. And they are an N of one, so it doesn't, for a lot of them, it doesn't really matter to them. So this has been tricky from a research perspective and from sort of a communication perspective, but it's important to know because you may be using terms that patients have no idea or even find offensive that could limit their relationship with you or access to care. Just to be very clear, I'm pretty sure you all know this, but there is a lot of conflation still of sex and gender. And while sex development and gender development are related, they're not the same thing. And I think it's important, again, just for level setting purposes, to be on the same page about that. Very oversimplified, sex development is what I've been talking about. So your chromosomes, your anatomy, your phenotype, your physiology, and gender development has to do with your gender identity, your gender role and behavior. And again, while these two things are related, they are not the same. And this has become, I think, acutely important again with the executive order that came out and how that applies to the different populations. But when we're talking about DSD or intersex, that really refers to people that have differences in their chromosomes, anatomy, physiology, et cetera. This almost violates the Johnson rules of slide making that I talked to the residents about last night. It's really, really close, but bear with me. This is sort of the framework that we use to teach the different sex development conditions. And I will try to go through it slowly, so bear with me. I find it most helpful to first think about how things happen in the binary way. So remember, way back in sort of embryology and development learning, first you have chromosomal sex established before birth. So that means usually you get 2 X's or 2 Y's, but not always. And then assuming that goes according to one of the typical pathways, the next step of sex development, of typical sex development, is the establishment of gonadal sex. So you make a testicle, usually if you have XY chromosomes. You make an ovary, usually if you have XX chromosomes. And then assuming all of that goes according to how it usually goes, then the gonads, either testicle or ovary, makes sex steroids, so estrogen or testosterone. And so then you get the phenotypic sex that corresponds to one of those pathways. However, in DSD, you can have something that goes differently about one of those steps of sex development, and that's where you get sort of those three categories. So first, you can have a difference in how chromosomal sex is established. So these are any of the condition where you don't have a 46XX or 46XY karyotype. Instead, if you think of these conditions in the most broad sense, any of these conditions, so Klinefelter syndrome, Turner syndrome, a variety of conditions with this mosaic karyotype, et cetera, will all fall under that category. So that's like category one. And then, okay, that chromosomal sex was established in a typical way. The next way that you can have something that goes differently is if the gonads don't develop in a typical way. So that's where for XY, you get like complete or partial gonadal dysgenesis, the gonads don't form at all, or you can have, annoyingly, ovotesticular DSD in all three categories, just to confuse things. And then with 46XX DSD, this used to be called sex reversal. This was one of the terms that was changed in that update, but it's sort of helpful for me to secretly think of that term still, even though we don't say it out loud anymore, because that's really what it is. Like the person has XX chromosomes, but on the outside, they have a penis and testicles that look typical. So then if sex chromosomes are established, gonadal sex is established in a typical way. The third way you can have a difference is if there's either a difference in androgen synthesis or androgen action. So these are like your complete and partial androgen insensitivity syndrome. That's probably one of the more common ones that you've heard, or congenital adrenal hyperplasia is another one. So those are this is CAH fits here. So that's that framework. If you're seeing one of these patients, if you're in this clinic and trying to think through what diagnosis they have, this framework is sort of how we teach this now. And you have to go through it a million times, but it is helpful to take a step back and just think through this framework. And they frequently cause atypical or non-binary genitalia or genotype-phenotype discordance. So some genital appearance is somewhere in between typical for a boy or a girl, or somebody with like XY chromosomes whose genitalia appear typical for a girl. Those are kind of the two common ways that these patients present. So I'm not going to belabor this slide too much, but there has been a long history of change as to how these patients are sort of thought about and cared for over the years. In the 1950s, there was this concept that there was a model of optimal care that involved assigning a binary sex to these patients, to have surgical treatment that corresponds to the binary sex, to have an environment that they were raised in that corresponded to what folks thought made sense, and to not have a lot of disclosure or any disclosure to the patient themselves. It was really thought that this was best. This is not something that was done out of malice or with a negative thought in mind at all, but it turned out that that was not great. And there was a lot of, I would say, angst in the community, and we heard about it, which I think was really hard and really good in a lot of ways, because it turned out that there were patients and individuals that were just very confused and did not understand their history, maybe had surgical complications they didn't understand, and were not happy about the way that they were treated. So I mentioned this consensus statement that came out in 2006, and a lot of that tried to respond to the critiques and protests that were understandably raised against the medical community. In addition to the terminology update, there's a lot of talk about multidisciplinary care, some more space given to like patient support and advocacy, those sorts of things. And then over the last several decades, we've really tried to start working together in a better way to collect data, to understand what patients really want, and to figure out how to get the best outcomes for this patient population. So this is just one example. Larry participates in something called the DSD TRN which I think in its next iteration is going to be the VSD TRN, where we work with a bunch of different hospitals to collaborate, share cases, and do research. And then most recently, there's been a big push to really change the paradigm around when surgical procedures are done for these patients. We at Lurie were, again, the subject of some protests and put a pause on external genital procedures that are irreversible, particularly clitoroplasty, a few years ago. And there has been the thought that this is a human rights violation to do any genitoplasty for patients who can't participate in the decision and consent for the procedure. I don't want to have the whole talk be about that, but I would say that it's really complicated for all the reasons that I indicated at the beginning. Like every patient and family is coming to this from a different space. And it may be, and you'll see in the case examples later, it may be that genitoplasty is the right decision for some patients with sort of informed conversation with the parents. So it's a tricky time right now to think about how to best care for these individuals. But as a program, we were basically, we really didn't have a choice but to put a pause for a while to sort of reevaluate how we all felt about this and what policy made the best sense for our institution. So that's where we're at right now in our program. So just to kind of summarize where we were and where we are, in the past, there was a paradigm of early sex assignment, and this was largely informed by surgeon opinion about how the genitalia could be reconstructed. So that sort of drove the sex assignment at birth, rather than the, I would say, more holistic assessment that's done now. This is talking about patients that have like atypical genital development. In the current paradigm, there are cases, not super commonly, but there are cases where we may delay sex assignment for like a few weeks. So we can get some information about chromosomes, about hormonal levels, anatomy before the family would assign a sex. And as I talked about with the last slide, early surgery is definitely controversial. And in general, we have a paradigm of avoiding irreversible procedures for patients who are not participating in the decision. In the past, there was also this emphasis on the gender appropriate environment, and most of these kids were growing up in a situation where there are very binary gender norms. And now we have, in general, a more expansive view of gender and sex to where different ways of thinking about how to raise a child might make more sense in our culture. And finally, as I mentioned, many of the patients that had DSD conditions in the past did not know about their conditions. There was a lot of secrecy, and psychosocial support was not really available or emphasized. And now, you know, of course, guided by the child and by their level of development, there's really a goal of transparency and definitely early psychosocial support. Families accept the early psychosocial support to varying degrees for sure, but it's something that we really do try to offer in different ways that would work for different families. So the current model, kind of going through what happened in the past, the current model is really of multidisciplinary care. And while logistically that can be very difficult to think about for like every child that might have one of these conditions in the United States, I think as much as possible, especially when there are questions about sex assignment or difficult conversations about surgery, having some element of a multidisciplinary conversation is really important. Knowing the history and knowing that there were patients who are now adults who were not happy about their care. We actually at our clinic saw a 50-year-old recently who was very confused about their diagnosis and came to us just for us to like review her records and have some counseling about what her anatomy was, what it is now, and if anything could be done to improve her sexual function. And so these patients are still out there. And even if you don't go into peds urology, even though I would hope that many of you do, you may one day have somebody that walks into your office that had one of these conditions that was cared for sort of in this different paradigm. So the specialties that I put on this slide, not every program has every specialty. but these are the specialties that tend to be represented in these different programs. Sort of how that looks and how often people meet and whether they see patients together, all of that does vary a little bit by program, but these are the general specialties that have expertise that's very helpful for taking care of DSD patients. This is our team. So we have, it's really big. We have this many people and we see like 6 patients. So it's not a big moneymaker, but it's really wonderful. And we have pediatric surgeon, 3 urologists. This crew includes research staff. The person in the middle is Adam is actually a medical student now and has one of these conditions, which they're very open about, and serves as the health educator in our program. And they did even before they were a medical student. So now they're an M1. It's just like super cool. We have 2 endocrinologists, 2 psychologists, and a psychology fellow, genetic counselors, our clinic coordinators, Danielle, she's a social worker. So we have a really big team, and I feel like we have a lot of different life experiences, religious, political, cultural, all of that, that you might guess based on how everybody presents themselves, and gender identity as well. And I think it makes for really hard discussions, but it's really good for our patients. As much as possible, we try to function in interdisciplinary fashion. So we often go together to NICU and clinic and see patients together. Often in the NICU, it's endo and urology, and we're amateur psychologists and genetic counselors, but at times those folks can join us as well. And then the full team is always available at the outpatient clinic. Danielle warns the families, you're going to be there for a while. It's usually like a couple of hours. And we might not all go in the room at the same time because that can be a little overwhelming, but at least a few specialties will often see the patients together. And we meet for an hour before clinic to kind of discuss the case and often debrief afterwards as needed. As I mentioned, this idea of external genital surgery or genitoplasty is very charged and controversial, and there are differing perspectives with limited data, which makes this really tricky. And a lot of the questions that are still out there, and sort of thinking about the question I was trying to answer with this talk about outcomes, we don't really know the long-term outcomes for patients that have not had genitoplasty. There are not a lot of patients that have their data recorded that we've followed and interviewed and asked about their lives over the years. We don't know about the long-term outcomes of the current techniques. So the techniques that are being used for genital reconstruction now are not the techniques that were being used for the patients who are now adults. So when the families ask you, well, what are your outcomes? You might be able to give them short-term outcomes, but we don't have fertility and sexual function outcomes on the patients, on the types of procedures that the patients are having now. And we definitely don't know the influence of growing up in a less binary society on the perception of all of these outcomes. So there's a lot of, I don't know, or I like speculation and kind of giving your best estimation when counseling these families, which some people find unsatisfying. This sort of lays out the extreme version of the 2 perspectives on surgery. The human rights perspective that I introduced in a few slides ago is that surgery for these conditions is never necessary. This is a natural human variation. It's not ethical for parents to make a decision about these procedures on behalf of their child. There's a lot of concerns about regret and the effects of genital surgery later in life. And there's concern, and we have this concern with some patients, where that their initial sex assignment might not align with their gender identity, and therefore you've done a reconstruction that was sort of not at all what they would have wanted for themselves. The traditional medical perspective that I was certainly taught in medical school, and I think that a lot of medical schools are still teaching, but there's some evolution there, is that doing a genitoplasty allows the child to grow up in a body that is aligned with their gender. And a lot of times that's true, but not always. And that parents frequently make other decisions on behalf of their children. And there's some concerns from surgeons that the surgery may not be as successful if done later, and concerned about the psychological effects of having genital surgery when you can remember it. So there are valid sort of points. I don't want to say both sides because it's not that helpful to pit people against each other, but there are valid points to think about from the 2 perspectives. And unfortunately, there's very little actual data to support either. It's really a lot about, who you are and who you've talked to and what you were taught. Sort of related, but a different aspect of surgery is gonadal management for these kids. So a lot of the DSD conditions do confer an increased risk of gonadal tumors. Typically, these are benign tumors called gonadoblastoma, but there's a concern that you can have what's called a dysgerminoma, which is a malignant germ cell tumor. And so the traditional paradigm for any of the conditions where there's a higher tumor risk is that these kids aren't going to have fertility. There's a high risk of tumor. You should have a gonadectomy if you're diagnosed with many of the conditions that I showed you on the other slide. And this in the more current evolving paradigm, we do have some expanded knowledge about possible fertility potential. There have been individuals with mosaic Turner, for example, that have evidence of gonadal function, spontaneous menarche, rare reports of pregnancy. We are able to provide a little bit more individualized cancer assessment, cancer risk assessment, although again, super limited because there's not a lot of people that kept their gonads that we followed. And now it's a lot longer, a lot more talking, but gonadectomy is typically recommended, or recommended at least to be discussed, but it's just a much more active process of deciding, I would say. And if it makes sense oncologically and with the family, if the patient can be involved, that's great. And we're balancing all these things when we're talking to patients about their gonadal management. So risk of tumors, potential for future fertility, this idea of autonomous decision making, so making your own decision about whether you want your gonads in and out or if it's safe, and then this possibility of endogenous hormone production. So can they actually produce their own hormones? Maybe that would be great. And there's one condition that we'll talk about later where it makes perfect sense. Sort of thinking forward, Hillary talked about how we're working on fertility preservation for this patient population. This is still considered highly experimental. We're not sure if it's going to work, but we did establish a research protocol for these individuals that they are eligible to enroll in if the family or the patient elects for gonadectomy. Expanded experimental pediatric fertility preservation options have been developed for cancer patients. So ovarian tissue cryo, testicular tissue cryo, and there's really promising data about being able to mature those cells and use those for reproduction. And so we sort of thought, well, could this apply to DSD patients? The honest answer is we don't know for sure, but the science is promising enough that we decided to offer this option for families. And so we discuss this and offer it to families of individuals who are having gonadectomy. And they have to store the tissue, they have to hope the science works, but it's an option that we've decided to offer. So let's move on to answering the question. What matters and to whom in DSD? Should I pause and see if there are questions or keep going? Keep going, okay. So when I take a step back and think about what outcomes might matter, we're surgeons, we think about the surgical outcomes, obviously, and sort of related as gonadal outcomes, although if you surge on the gonads, they're not going to work anymore. So we're thinking about when to surge and how and why. Of course, the psychosocial outcomes, which I wasn't really taught to think about much in training, but think about a lot now that I'm the one doing the counseling, and then just some sort of stuff I put in the sprinkle of other. So under surgical, we would think about cosmetic outcomes of how things look, sexual function, voiding, urinary tract infections, pain. Those are the sorts of things that we tend to publish on, right? Because it's what we can see and what we think about and what we ask about patients most commonly for our patients. As I talked about with gonadal management, we're thinking about cancer outcomes, fertility, and hormonal function. For psychosocial, there are lots of studies about quality of life. There's some studies about gender dysphoria in this patient population. That's sort of where that overlap in between DSD and gender comes. Depression, anxiety. And then other and sort of related things that I think are really important are this idea of decisional regret or decisional conflict. It's really hard to think about either being the individual with one of these conditions or the parent. Like projecting what you're going to want later is a lot of what these people are trying to do. And that's very difficult when it comes to things like sexual function and fertility. If you're 14, I didn't want to have a kid till I was like 35. I don't know, right? And if you're 14, And thinking about, you're probably going to say, no, I don't want to like store my tissue. I don't, that sounds crazy. Who wants a baby? But you're not sure what you're going to want 20 years from now. And then transition to adult care has also been really tricky. As I mentioned, we had this 50-year-old that came, and we'll pretty much just see anybody once or more than once if it serves their needs, to try to get them to an adult care team that makes sense, but there's not like an adult DSD clinic at Northwestern that we can send them to. So we have to try to, we'll usually see people and assess their needs and figure out what makes sense as far as adult care, but there's not the same care model on the adult side. And as I mentioned before, your perspective also really matters when it comes to thinking about outcomes in DSD. So as I mentioned, we as surgeons think about cosmetic, what is their post-op urinary sexual function? We think about oncologic outcomes. If you're the patient, at some point, you're probably thinking about your fertility and sexual function, your urination, your quality of life, depression and anxiety, pain. So there's some overlap, but they might not be all the same as to what we would think of as successful outcomes as the surgeons. If you're the parent, you also, I would think, want your child to have a good functional and cosmetic outcome. But this is a lot of the time where this decisional conflict, like maybe the two parents don't agree, or maybe the parent and the child don't agree. We've done some qualitative interviews of parents and patients about their decisions about gonadectomy and fertility, and they don't always agree about what to do and what makes sense or why. And certainly there can be some depression and anxiety. We're just switched how we're collecting this information in our clinic, but we're collecting more about the parents' sort of anxiety related to their child's health condition. And it's for this condition, these conditions, it's often lower than you might expect, but there are some like select families where they have a lot of anxiety trying to think through this and make decisions on behalf of their child. And then as the endocrinologist, they're thinking about hormonal control and bone health and those sort of growth. Those sorts of things are what they're focusing on, along with really collaborating with us on like the fertility aspect of things. So I just picked out like a few examples to try to pair the like what outcome are we thinking about and who together to show the different types of studies that are out there and thinking about these patients with DSD. So the first example takes the perspective of the patient, looking at quality of life of 70 women with these conditions, and they're really looking, this is a psychosocial outcome. And this is a study where they looked at quality of life amongst a group of patients with a variety of diagnoses, which can be tricky. It's one of the issues with trying to study this population, as you saw from the diagram, CAH is not the same as CAS, but we kind of put them all together in a lot of the studies because otherwise you would never be able to recruit and learn anything. And not surprisingly, quality of life was lower than controls, and depression, anxiety, suicidal ideation were higher. So just an example of that. The next example is a little more recent study. This is from Indiana, some of our colleagues that we know, and they talked to parents. And I put this in the other category, sort of decisional regret. They had almost 40 parents of children with CAH who were having feminizing genitoplasty complete the decision regret scale. As I mentioned, this type of procedure is very controversial, and Dr. Szymanski in Indiana, along with others, are trying to generate some data to help inform what we should be doing as a field. And the bottom line with his study is that the decision regret was very low, and lower actually than hypospadias and tonsillectomy, which was interesting. There's certainly limitations of the study as far as how they sampled their population and how old the patients were, and they didn't ask the patients, which ultimately that's probably more important. But I do think it's interesting that, especially the comparison with hypospadias. This is another example, again, some familiar names from the pediatric urology community. Now Amanda Buchanan, who's in Kentucky. I think this was when she was a fellow. And she looked at, this is again, surgeon's perspective, surgical outcomes, not surprising. This was their retrospective review comparing hypospadias outcomes, patients with DSD, which is tricky because many patients who we might think of as having some sort of condition don't have a genetic diagnosis. And so with that caveat, they compared the patients who had a known diagnosis who had surgery with patients who had like similar phenotype but didn't have a known diagnosis. And their primary outcome was reoperation after hypospadias repair. You'll see no matter what, it was really high. And it's a small sample size, so I think it's hard to know. But they found that the reoperation rates were higher among patients with DSD. Other studies have not necessarily confirmed this finding. So I think it's important to know that this is not, I wouldn't take the result as fact. This is more an example of this type of study. And then this fourth study, it looks from the perspective of an endocrinologist and thinks about gonadal outcomes. There's a lot of talk about AMH levels in the endo world. They love talking about this stuff related to Turner syndrome and other conditions. And they're trying to correlate AMH levels to see if that was predictive of patient function, which would be really helpful if it worked, because this is one of the things we're thinking about in gonadal management counseling. So in this study, they found that AMH correlated negatively with LH and FSH. So if you remember, it's another like steps in the pathway, but your brain makes LH and FSH that tells your gonads what to do. And AMH is another marker that may correlate with gonadal function. So if your AMH is low, you would think your pituitary hormones are going to be high to try to be driving your gonads to do more. So this all kind of makes sense. And in this study, not surprisingly, the presence of AMH was associated with spontaneous gonadal function. And our endocrinologists, as a result of this study and others, now are much more like routinely relying on AMH to help guide their counseling. So some limited long-term outcome data are becoming available, but it's still really sparse, and we do a lot of speculation and just trying to help talk through what might be best with each family. This is one example from the DSD Life study, where they looked at outcomes after surgery, which is hard because there's not that many surgeons that participate in DSD Life. And there's a really wide range of what was considered surgery in this study. But there's a reasonable proportion of patients and physicians who were not satisfied with genital appearance, and 1 in 5 had concerns about function. And they stratified that by males versus females and sort of appearance versus function, which you can see here. I'm going to move along to make sure that we have time for discussion. And as I mentioned, there was this paper, unfortunately, even though they had a big sample size, there's not a lot of surgical details. There's no comparison pre and post surgery. So there's a lot of limitations that make this difficult to practically apply to our patients. All right, so in the last like 10 minutes or so before we have discussion, I just want to take you through 2 case examples. These are stylized, and it's sort of a choose your own adventure, but I hope to show you how I think there's like multiple ways that patients could kind of move through their medical care who have these conditions and have like a happy life and be successful. So the first is an infant with genotype-phenotype discordance. We're seeing this all the time. Newborn baby, Y chromosome material on cell-free DNA, because everybody's getting that at like, 10 weeks or so. And then they have female typical genitalia on ultrasound at 20 weeks gestation. And the birth exam in this patient confirmed female typical external genitalia. You always want to confirm a postnatal karyotype. That's like one of the genetic counselors want to carry a sign that say, always confirm your prenatal karyotype with a postnatal karyotype. So we did that. XY chromosomes and androgen receptor testing confirmed a diagnosis of CAIS, which would be the most common condition that would present this way. As a review, if you have CAIS, you have XY chromosomes, your body makes testicles, you make AMH, you don't have a uterus, and the testicles make testosterone, but there is a variation in the androgen receptors, so your body doesn't respond to it. So these patients have goo gobs of testosterone, but their body shows no effect. So their external genitalia looks like a girl, internal genitalia, no Mullerian structures. Usually these people identify as female, And they keep their gonads, they make testosterone at puberty, and then that gets peripherally converted to estrogen. So they'll have breast development and they'll go through spontaneous puberty. They don't usually have much pubic or axillary hair and not much body odor, but they'll have basically a female typical puberty. And their germ cell tumor risk is increased over baseline people with testicles, but it's not that high. Like 2 to 10% is what we quote. So for this newborn, we have a multidisciplinary meeting with the family, talk about the diagnosis, anatomy. We go through the same sex development stuff with pictures that I presented to you. Reassure them that there are typically no medical or surgical needs that need urgent attention, and I recommend outpatient follow-up. This patient has inguinal hernias noted at 1 year of age, which is pretty common for this condition. Some patients actually present this way, where they have inguinal hernia repair and they're found to have a testicle rather than an ovary. So that's surprise sometimes. And you can think about scenario 1, where the family elects for gonadectomy. Scenario 2, they retain the gonads. So with scenario 1, we talk about gonadal management options over multiple multidisciplinary visits. And the family elects for a gonadectomy with a bilateral inguinal hernia repair. Kid does well, starts estrogen at 12. Hello. Should I answer? Okay. Oh, that's you. Okay. I thought it was like a radio. I don't know. In scenario 2, same thing, lots of talking, multiple times. This family elects for bilateral inguinal hernia repair and keeping the gonads in a location where we can monitor them. Again, does well, monitor yearly with ultrasounds. And this patient has endogenous puberty, as I talked about, where they make gougobs of testosterone, peripherally convert. And then after talking with the patient another bunch of times, the patient elects for gonadectomy with gonadal tissue cryopreservation when they're 16 and then goes on estrogen. Throughout all of this, either way, they have multiple multidisciplinary visits, psychosocial support, and gradual disclosure over time. And a lot of times, like, the sort of urgent issues with these patients are like early childhood or whenever they're diagnosed, and then like expected time of puberty, and not much happens from our perspective in between. But it's super helpful if you know that kid before they're 12, if you're going to be talking to them about hormone replacement, surgical options, all that stuff. So we still have patients come back every year or two just so they've like seen our faces and know who we are. So now she's 17 and had a gonadectomy. This patient expresses a female gender identity, which is consistent with their sex assigned at birth. And the things that we think about for this patient would be how they're going to do their estrogen replacement, what are their desires for their vagina. And so there's sort of another branch point where this could, where the discussions could sort of go either way. In one scenario, the patient says, yeah, sure, I think I might want a vagina that I can use for intercourse at some point. And in the other scenario, they say, no, thanks. I think a lot of times there's an assumption that they're going to want that, but I've had at least one patient who was dilating because she thought her mom wanted her to, and she'd been coming back and talking about dilations, and finally she's like, oh, I'm gay, I don't care. My mom thinks if I do this, I'm going to have a boyfriend. It's like, okay, we both know that's not true. If you want to come back and just talk to me and come to clinic, that's fine, but just know that like you don't have to do this. So I try to make sure that I don't assume what they want for their body and actually talk to the patient about that. So in the first scenario where this patient is interested in possible like dilations or reconstruction, estrogen patch, female gender identity, identifies as heterosexual, and typically for CIS patients, they will be successful with vaginal dilations. So often they won't need a vaginoplasty, and having sex, open to family building through adoption. She understands her diagnosis, transitions to our magical adult care land that we're still working on. Again, stylized scenarios. Scenario 2, she's not interested. She's on estrogen. She identifies as female. She identifies as asexual. We talked about vaginal dilations, not interested. She has her gonadal tissue stored if the science works for the future. She understands her diagnosis, and again, transition to magical adult care land. And just like before, we continue our multidisciplinary follow-up, psychosocial support, and now we're starting to talk about transition readiness, which in the current paradigm is turning out to be us educating the patients about their diagnosis. And we're talking about, like, do we need to give them a passport that they can have? We haven't quite done this yet, but that's sort of what we're thinking about. They may need to do more advocacy for themselves than potentially would be ideal, but at least having like a one pager with their anatomy, inventory, and basic information about their care, I think may be what we end up with for now. So just to summarize the two idealized scenarios for this now young adult with CAIS. In the first scenario, she had early gonadectomy, did not cryopreserve tissue, is on an estrogen patch, female gender identity, heterosexual, vagina is working, and she's open to family building through adoption. In the second scenario, she has a gonadectomy after puberty, did preserve on pills, etc. So I think there's many ways that this could be a happy ending, but both had gradual disclosure, psychosocial support, multidisciplinary follow-up, and transition to adult health care. So those are kind of the common threads that we would like to weave throughout the two scenarios. The second scenario is an infant with atypical genitalia. So this baby was born at term, no significant prenatal history. The exam at birth showed a prominent clitorophallic structure. Labioscrotal folds rugated with posterior fusion, no palpable gonads, and a single opening they can't really see, but it would be there at the base. And this is an ultrasound just showing the bladder in the front and the uterus with the endometrial stripe in the back, so confirming Eulerian structures. This baby has a karyotype of 46XX, has an ACTH stimulation test to check adrenal function that was found to demonstrate a markedly elevated 17-OHP, which is consistent with the most common form of CAH. So the immediate recommendations for these babies, and this is the like dreaded case that comes up on the boards. Where's he? It's not dreaded for you because he does this stuff, but for all the adult urologists, they're like, oh, please don't give me a DS2 case. But this is the one that may come up because this is the one that can be life-threatening in the neonatal period. So they need supplementation with hydrocortisone and fludrocortisone, not immediately, but they typically salt waste around a week of life if it's going to happen. So this is like, you can't miss. This is on the newborn screen now, as Larry talked about yesterday, but they need to be monitored if you suspect this, and they need to be treated with steroids to make sure that they're safe. The family needs to be educated on stress dose steroids because if the baby is sick or if they have surgery, they need extra. Sometimes they end up coming to the hospital when they have viruses and stuff just because they get sick. And the management around the genital appearance is for outpatient multidisciplinary follow-up, just like the last patient, including complex ongoing discussions about surgical management of CAH. So there's a very simplified cholesterol pathway because it's early and that's stressful. But if you remember learning about this, so again, this is one where the sex development is established as typical. They make ovaries, they have a uterus, and this is an adrenal issue. So the sex development is typical in many ways. And some people with this condition don't actually identify with the DSD or intersex labels because they say, well, this is an adrenal issue. This is not really a sex development issue. But in this case, because the 21 hydroxylase acts in this part of the pathway, and they don't make this stuff, then all of the cholesterol metabolism shunts to the right side of the pathway, and they make excess testosterone. So that's the reason why their genital appearance is different, but why everything else developed in a way that's typical for a girl. So these patients make a variable amount of testosterone, and so therefore the amount of androgen effect that you see on the external genitalia can be highly variable. So you might see like a little bit of clitoromegaly, or you might have an appearance that looks more like hypospadias. As I mentioned, the internal genitalia are female typical, and we talked about the salt wasting, which is the most important immediate concern. The gender identity is usually female, but there are a lot of reports of more like male typical gender identity. There's like stereotypes about all the CAH tomboys, higher chance of identifying as not heterosexual, etc. And they make estrogen, they have eggs, and there's not an increased risk of germ cell tumors. All that stuff about gonadectomy does not apply to CAH. Typically, these patients are assigned female at birth, and that was the case for this patient. Had endoscopy that confirmed a high confluence UG sinus. Kid had one admission for stress dose steroids and had ongoing follow-up. So you can imagine scenario 1 is early genitoplasty, scenario 2, defer. So in the early scenario, this kid has a clitoroplasty, UG sinus mobilization, labiaplasty at a year of age. Expresses a female gender identity, identifies as bisexual, has some stenosis, which is common. We quote like a 50% rate of needing something done in adolescence. She expresses a desire to use tampons, and so has a little introitoplasty at 15, and has a pleasurable sex life, understands her diagnosis, and transitions to adult care, just like that. Scenario 2, we decide to wait on any surgical management, to discuss genital surgical options, but the family elects to defer. This patient identifies as non-binary and pan and is totally happy with the way their body functions and looks. This person also understands their diagnosis and transitions to adult care. You'll see again, these are stylized, but it's my way of sort of emphasizing the point. Again, these patients have the multidisciplinary follow-up, psychosocial support, gradual disclosure, and transition readiness. So summary of these patients, the first one has an early genital reconstruction, has a minor procedure in adolescence, good hormonal control, happy with her vagina, bisexual, and is satisfied with her care and has transitioned to adult care. In the second scenario, the person identifies as non-binary, so it's perfectly fine that their genitalia matches that and is also satisfied with their life. And same thing as the other one, they both have all these common foundational aspects of their care in common. So to sum up with a couple of minutes, hopefully, for questions, DSD care is complicated, it's evolving, it's highly individualized, and I really do think that multiple pathways can lead to a successful outcome. It's just really hard to predict when you have a baby in front of you, like which way makes the most sense. But I think there's a lot of ways that this can go that would work well for patients and families. How we define success, I think, is important. It's based on sort of outcomes measured and priorities, but the perspective that we're thinking about is also really important, and we just have to be careful not to be too surgeon-centric and thinking about what's best for these patients and the families. And the future, I think, includes, to the extent possible, continued multidisciplinary care. I don't think this is going to get easier. Would like to contribute to continued research, although getting research funding for DSD is really tricky, and really trying to partner with patients and with advocacy to decide together what's best. So that's all I have. I really appreciate your time and your attention.